Good afternoon, everyone, and welcome to Grand Rounds. My name's Tom Fodden, and I'm a chair and organizer of Grand Rounds. I said in my email yesterday that it looked like it was going to be cold, and lo and behold, we woke up to snow this morning, so it's only going to get worse. But I've still got to get out and do my marathon run, so it'll be crampons and ice axes for my 5K this afternoon. John will be wondering how he's going to get out on his bike in this kind of weather rather than out in his running shoes. But as we all know, there's no such thing as adverse weather conditions, just inadequate clothing. So I'm sure we'll all get out. Right. So I'm always delighted when ophthalmology speak at Grand Rounds. It's no secret that I have eyes. My eyes are fairly fragile and require careful attention. And I've been very lucky over the last nearly 20 years of being in Dundee to have the excellent ophthalmology department in Tayside look after me and my eyes, not least John Ellis, today's speaker, who has, and I say this and he'll do that at me, but he has saved my eyesight on more than a few occasions. So I'm fascinated by eyes, and I pester him to come and speak at Grand Rounds, and he's agreed on this occasion to come and speak about the work that he's been doing, not as a vitreoretinal surgeon, of which he is of some repute, but in this occasion about cataract surgery. So I'm really looking forward to this. I think it's going to be very interesting stuff, and I should just take every opportunity to thank John for saving my eyesight on numerous occasions, and I'll thank him again. So any questions you have, please stick them into the chat box. We'll get to that at the end. And John, thanks again.
Tom, that's incredibly gracious. Thank you very much, and it's a real honor. I suspect there aren't any ophthalmologists on the call, and I have to say to any chest physicians or urologists or any other trade that is tuned in to watch a talk on ophthalmology and cataracts, that you have my respect and thanks, because you could have argued that this wasn't really in your territory, but I think there are some transferable lessons on anything that's done at volume or scale. So let me just launch in. I hope I won't slip into jargon that's obscure or arcane, but there is one phrase that I will use that you need to know. So when we take out a cataract, modern surgery uses an ultrasound probe that is 2.75 or 2.2 millimeters in diameter, so it doesn't need to be sutured. And that is called a phaco, Greek for lens, emulsification, phaco just for short. So phaco has become synonymous with cataract surgery. So having a phaco is the same as having a cataract ops. If I say one or the other, they're both interchangeable. So you'll see from the title there, the acronym HVLC. So what happened was, a couple of years ago, Britain realized there's a crisis in cataract surgery even before the pandemic, and talked about high volume, low complexity. And we'll come back to that. But actually, what the Royal College put out last year was, forget the low complexity, just call it a high volume cataract list. And that is what we do in Tayside. We do not stratify. So the reason I was late was that my brilliant registrar wanted me to supervise a particularly complex case. And these are the kind of cases that, some years ago, consultants would be having coronaries over, and now these are just franchised out to registrars. So at the peak of their kind of dexterity, I would say. So Dundee high volume, and in fact, what I would contend is that we need to stop calling it anything. We just need to call it cataract lists, because high volume implies there is another kind, and that the end game for where I want to get to in Scotland is that there is only one kind of list, which is that they're so high volume all the time that nobody can remember a time when surgeons did hobby lists. And those days are over. The national anguish cannot afford surgeons doing just a little bit of hobby surgery. The constrained resource use is that we have managed to do what we've done, which may or may not impress you, but it is what we've done without any extra cash, without any extra manpower. So this is within a restrained physical facility with restrained human resources. So the question is, what can you do with what you've got? And the various things peppered around the edge of the slide are because this was presented or has been presented at kind of national meetings. So cataract is a public health crisis, but cataract really is a public health problem because it's not really a disease. If you live long enough, the main risk factor of having a cataract, as I say to my patients, is too many candles on the cake. So we're all going to get it. So that, you might say, is enough gravitas to say that's a public health crisis there, because everyone wants to see things. But actually, I think it's bigger than that. And a rather remarkable study was published in JAMA in February of this year, KPMG data. So this was called the ACT study. The acronym stands for Adult Changes in Thought. So adults were followed from the age of 65 till either death or dementia, whichever comes first. You can see the numbers on screen. But total, that is 23,554 man years of follow-up, to be pedantic. That's a lot of observation. See, with all that follow-up, they found something very interesting about cataract surgery. And here's the bombshell. That cataract surgery led to a 30% risk reduction for dementia. So the relative risk 0.71 with the confidence interval 0.62 to 0.83. So this is a statistically significant reduction in the risk of dementia. And it was preserved for up to 10 years. And it happened even with one eye only. So your first eye, cataract out, even if your second eye didn't have the surgery, still gave you that benefit. So in contrast to most speakers who would tell you to please pay attention because everything I say is important, I'd like to advertise that you should get highly distracted, pull out your mobile phone, tune out of what I'm saying. And if by the end of the talk, you can come back online and tell me any other healthcare intervention that has a 30% risk in the risk reduction for dementia, then I'll take off my hat to you. So I don't think you will. And I think, therefore, what the Scottish government should be doing is compulsory retraining of psychogeriatricians to do cataract surgery. So I did a kind of back of napkin. I wondered if you could work out an NNT. And what I'm trying to work out is how many cataracts do you have to do to keep one person out of a nursing home? So the mean age of cataract surgery is 76 in the UK, or at least in Scotland. That's pretty sweet because the over 75 data is that 1 in 5 people will die in a nursing home above 75, and 1 in 4 of those deaths will be due to dementia. That's what the death certificate will say. So you do a bit of maths, and let's say 1 in 20 is the absolute risk, because as everyone knows, the NNT is 1 over the absolute risk reduction, not the relative risk reduction. So control event rate minus experimental event rate. And you get the kind of numbers I've got at the bottom. Clearly take this all with a huge pinch of salt, but every 69 operations we do may keep 1 person out of a nursing home. And there's the there's the confidence intervals there. Now, since February of this year, we've done 1,400 cataracts on Thursday. So we've possibly kept something like 20 people out of a nursing home. So that is a phenomenal public health good. I was driving through Arbroath Road, and outside a newsagent saw this poster, had to stop the car and take a photo. I have no idea what surgery is being referred to, but this is the kind of catastrophe that the public are only too well aware of. So if we stick to kind of self-preservation, if we have the Harley Street model of healthcare, which says I will take no risk and I will have a very detailed preoperative discussion for half an hour with every patient, I guess I might not be sued by the patients I operate on, but what about the great good that I cannot do to the people I never meet? Now, Tom McDonald, whose face I saw there and whose name is on screen, actually, you pointed me to this, Tom, 20 years ago. The HOPE study was the heart outcomes prevention evaluation, 55-year-old and above type 2 diabetes on ramipril. And the really fascinating study result was that the investigators, the data monitoring committee stopped it early and it rushed to press because there was a 26% all-cause mortality reduction on people in ramipril. And Tom pointed out back then that you could imagine a class action suit against GP practices by their patients for saying that being on no medication is leaving me at risk. In fact, the non-risk state is to be medicated. And therefore, every GP who read this paper on the Monday morning should go through their entire list and pull everybody's not on ramipril with type 2 diabetes over 55 and start them on it. So you have a paradigm there where not doing a health intervention, the great untreated are actually at risk. And so my point from the ophthalmology thing is that that's the case with cataract patients. So what are the ethics? There are harms from not doing enough surgery, not doing enough healthcare. And Voltaire famously said that perfection is the enemy of the good. So if you wait for the absolutely perfect health paradigm to come along for cataracts, there's a heck of a lot of stuff you're not doing. And just to speak into this, it's really interesting. I think clinicians assume that management's quite naive about the kind of cold-faced stuff that we do. But I'll read to you what Tayside's management says, and I think this is chock full of common sense. Quote, NHS Tayside recognizes that it would be both impossible and unrealistic to try and eliminate all risk from our activities. The most effective staff are those who are prepared to take calculated risks based on a range of detailed options. NHS Tayside believes that by approaching the management of such risks in an organized manner, the implication of those risks can be reduced to an acceptable level. So what it's saying is, go out there and just make a difference. And of course, it's not risk-free, but that's what your big salary's for. Now, let's have some demographic stuff here. I mean, this is the dependency ratio, the ratio in the bottom line going from 3.16 to 2 point something is the number of people in employment to every one retired person. And clearly the demographic bell curve moving up means that by 2035, I mean, in sociological terms, these are massive, massive changes. So we don't have enough people paying the salaries. We don't have enough people. We have plenty of people wanting the operation. We don't have enough surgeons. And I'll unpack that a bit. This is myopia. So this is the world population and short-sightedness, which is a risk factor for many things, as Tom will tell you, different Tom this time. So at this point in history, 23% of the world is myopic. Blue means low myopia up to -6, and 3% is above -6. The reason they've chosen that number is that if you don't have specs, if you live in the poor world, 2/3 majority world, if you don't have specs, you are WHO blind just because of myopia. So that's 23%, and here it is moving to 46%. So 46% of the world will be myopic. And the question is, when are the 2 years that these two graphs relate to? So is the 23% back in the 17th century? Well, the figure on the left is 2000, the year 2000. The figure on the right is 2040. In other words, in 40 years, these are the kind of numbers that 700 million people in the world, almost 1 billion people, will be myopic blind. Now, the problem with that in our health context is that these myopic patients monopolize your surgeon's time. So he's spending so much time dealing with glaucoma and retinal detachments caused by myopia, he doesn't have time to do cataract surgery. So the VR surgeons are doing less and less cataracts. Our oculoplastic surgeon in Tayside hasn't done a cataract for 3 years because she's got so much work doing skin tumors. She's retiring early next year, and her post has been advertised, and we have had not a single applicant for that post. We've twice advertised for a pediatric ophthalmologist and got no applicants. So surgeon numbers are collapsing. We don't have enough surgeons. We've got a dependent population, and we have a problem. So the Scottish government, I speak with the up-to-date data that I have, which is to say nobody's told me otherwise, is planning to build various treatment centres around the country. The Jubilee is the only one on the West Coast until later this year, when the key is turned on the Inverness Centre, and we're hoping that a Perth Centre will be built circa 2025-26. We got a graphic designer to commission a logo for Perth, and you can see the eye clearly outlined there with the notion of care supporting it underneath, and Perth being the sort of geographical centre of Scotland. So how much do backlog-wise, how much do we have in terms of the problem? And then the title of the talk was, what is the magic sauce? And I really just want to end with a note of whimsy and kind of seasonal goodwill and speculation. I genuinely want to try and work out something, and I'll put it over to you and see what you think at the end. So what we all thought was that coming out of COVID, the bow wave of blindness might be serene like this, but in fact, that's more realistic, isn't it? It's a crash. We are heading into major, major troubles post-COVID. I qualified in 1989, and between 1989 and 2004, the cataract surgery rate in Scotland had gone up 3.7-fold. So it almost quadrupled. And the CSR, as it's called, the cataract rate per million population, has gone up from the 90s to pre-pandemic levels, as you see. And round about the middle of this decade, it needs to hit 10,000. You can ignore the lower line and just use the per million figure. The crude unadjusted figure is used worldwide. So we need to be up at 10,000 per million. So the numbers are just going to keep going up. Now, in England and Wales, this is south of the border, the data on this screen, where is cataract surgery currently being done? Well, almost half of it is being done in the independent sector. And if you look at the red line, which is NHS going down, and the blue rising, which is I suppose blue is the color of Conservatives, isn't it? So that seems vaguely appropriate. This is the doctors working in the independent sector being paid massive amounts of money to do cataract surgery, which isn't because the patient's affording to go private, it's because it's coming out of your taxes. But the same surgeons who can only manage 6 or 7 on a Monday to Friday, seem to be able to manage 9 or 10 on a Saturday. And that's where the surgery is being done. I don't have the data for Scotland, but we do have the independent sector active north of the border. Now, the average age of cataract surgery in Scotland is 76, and by birth cohort, life expectancy for men is 80. Let's just stick with that figure, which means all things being equal, the average patient, and we know that all generalizations are wrong, has got 4 years left to go. So if his waiting list is 1 year, he spends 25% of his remaining life expectancy either having surgery, waiting for surgery, or in the queue. And that's just not acceptable. Now, these are the figures for Scotland. So the x-axis is in thousands. So we did in just before the pandemic, 35,700 cataract surgeries in Scotland. And the best data that we have is that right now, we have something like 59,000. I'm going to take off the scale, I'll explain in a second, but 59,000 is up there. In other words, we are now in Scotland where we would not have expected to be until the year 2036. But by 2036, we might have expected to build new hospitals and have new stuff, and we don't have any of that. And the red triangle clearly is the triangle of misery. Now, the only question that matters to me, and the reason I've taken off the scale, is that I've no reason to believe Tayside is different in terms of trajectory. Presumably it's the same. The scale is the same. The absolute numbers are different. And the only question I want to know is how quickly can we rematch the trajectory? So it's still going to go up because of the aging population, but can we diminish the red triangle of misery? Now, I knew when I came back in February and got the post that we had 1,500 patients, and we were working pretty flat out from February, and the number was pegged at 1,500. It stubbornly refused to go down. So clearly we were listing more than we were taking out of the pool. And I'm pleased to say that it's just beginning to go down. We're now at about 1,300. And I would hope that by about April of next year, we might be getting down to 2 or 3 month wait, which is almost at the 18-week RTT that we all used to have prior to the pandemic. I did a bit of a blitz in March. This is a pie chart of the 380 patients that I saw, or at least that I clinicked. It was a phone clinic, and how they were listed. So the orange on the left, the kind of amber color, the acronym ISBCS stands for a really novel strategy that we're doing in cataract surgery. The acronym is immediate sequential bilateral cataracts. You get the two done on the same day. Now, historically, there's been a bit of a resistance to that because of the nervousness about bilateral infection. But if you can put somebody into the ISBCS and get 2 eyes done, clearly it's a one-stop, one surgery, fire and forget thing. At best, we can have start of first eye to end of second in 15 or 14 minutes. And what we do is we do 1 eye. If the patient is happy for me to continue, I re-scrub, new gloves, new gown, new scrub nurse, new trolley, new instruments, different batches. In fact, we've been using different factory suppliers, different suppliers for the disposables and the chemicals that we use. So what I say in my MP3 that I click into an autopilot to my patients is, it's as separate as 2 different occasions in the calendar, collapsed into one by a magic time machine. So we are segregating the microbiological risk, we think, but putting it into one visit. Now, if you had to get 1,000 patients, of whom 60% have bilateral pathology, if you're only doing 1 eye 1 day, clearly that's 1,600 theatre visits. If all 600 that are bilateral want ISBCS, then clearly it's 1,000 theatre visits. And the economies of scale mean that patient transport and turnaround, you're doing far more in the ISBCS than you can do in unilateral surgery. A couple of other stats from that. The blue is just the unilaterals and why they were unilateral. You can see that almost 40% had already had 1 eye done anyway. 45% genuinely had no symptoms in the second eye. And the 6% had either a glass eye or a blind eye on the contralateral side. Now, when I came back in February, I said to the nursing team that what I wanted to do was try and virtualize 1 day of the week. I wasn't saying that every day should be high volume, but could we do it? And the motto that we had for about 6 months was, I wanted the staff to feel they were going home having been more busy but less tired. And I think it's true to say that has been the case. If you ask the nursing staff, they would say, yes, that's true. They quite enjoy the high volume day. And we'll talk about why when we discuss the magic sauce at the end. So this is management speak. When you form a team, you form the team, there's inevitably a storm. There's either internal or external attack. You might fall out with each other, or there might be pushback against such a team and what it's doing. You then settle into normal, and then you just get on with it and do it, so that, as I said at the start, hopefully everyone forgets that there was ever any other way of doing it. It is just the normal way that you perform. And I think we've done that. We have had kickback and storm, but we're kind of getting through that. Now, right back at the start, there were 7 modifications, things that we thought we could change to up the fluidity. And patients used to wear hospital gowns. Now they just come in their own clothes and shoes. We don't put in preoperative drops. We just give a strong mid-rheatic straight into the anterior chamber. We batch the arrivals of patients, so they come in 4 2-hourly things, 8 a.m., 10, 12, and 2 p.m., 6 patients at a time. The genius of that is that instead of going 8:05, 8:15, 8:30, 9 o'clock, if one no shows, there's another 5 you can draw on, and we don't have to stick rigidly to order. We then have jump seats. Some of these things I'll leave because they're just very, very in-house for ophthalmologists to fuss about. But the point was that we took a pretty unglamorous ante-room that used to have a bed in it and just put these 2 seats so the patients walk around and sit down. And the 4 suggestions highlighted there in blue were all made by the nursing team. Not one of those was really my idea. And they have revolutionized what we've done. So that if you look at these sort of fairly representative theatres from May and June, in one theatre in one day, this is a 2-session day, morning and afternoon. We're doing 24 if it's a single eye, and up to 32 if it's mostly made up of bilaterals. And the day where there's a 22, and I think one of the other days that are small numbers, I had a procurement meeting, which is an hour of my life I'm never going to get back. And then in August at the changeover, I was given another theatre. So we had, in terms of physical resource, ophthalmology has 2 theatres, and I had a half day in the second theatre in the morning, and I was given senior registrar trainees so that one of them could do one of those lists. And you can see the numbers have gone up. So that's a 3-session performance of 38, 49, 45. To put that in context, a whole day used to do 12 last year and pre-pandemic. So we've more than doubled the numbers. And this, yeah. So we then got a medical student called Lynn. I'm grateful for her analysis. Just casting your eye over that without scrutinizing it. This is fairly familiar sort of stuff, looking at the turnover time and the surgery time. So the center of the arrow is incision to closure. So the surgeon tends to think that that's the only thing that matters. But of course, that is the smallest part, as you well know, of all that goes on. And if you can get gains in the rest, the cycling thing, David Brailsford very famously, the gradual accumulation of marginal gains. If you can get wins in those parts of the day, you can increase the throughput. So Lynn looked at 111 cataracts. Phacos is just, as I said, the synonym for the surgery. There were 3 of a different kind, which are more time consuming. Most units would not mix these M6, as you see there, into what they call a high volume list. But we, as I said, we have no stratification. So I'm expecting myself and the registrars to do all comers. So that's patients who can't lie flat, patients with every kind of dodgy risk factor that just are all mixed in together. Now, if you look at this, the 1, 2, 3, 4 high volume lists, the reason that the second one is in brackets is that's only a half day. So the reason that's 12, it's just a morning. The rest are all day lists. The patients, when it says 18 is, and yet the eyes are 26 and 27 on the right of your screen, that's because these are bilaterals, some of them. And then the standard list, 1 and 2 with 13, 13 and so on. What is really interesting to me is that in order to deliver high volume, takes only 1 more salary, 7 nurses as opposed to 6. That's a pretty impressive return on investment. Now, when you look at the high volume, the entry time, it doesn't matter too much what these are, turnover, duration, and so on. You can guess what they are, and we would waste time unpacking it, but the concept is easy to understand. Look at the statistical values. The entry time is massively better, and so on and so forth. The only one that doesn't differ statistically, I mean, I couldn't have wished this to turn out better, really, is the surgical time. And if I go to my colleagues around the rest of Scotland, when I said form, storm, norm, perform, the problem with the high volume list is it's perceived as a threat to standard operating units. Many, I'm not saying all, many units would say, look, you're talking about rushing surgeons, you're asking us to work faster, this is unsafe. We think this is unreasonable. We're all working as hard as we possibly can, etc., etc. But if you notice, Yes, the standard list surgery takes half as long, again, 15 minutes as opposed to 10, but in fact, that doesn't differ statistically. Now, the geniuses among you will know that if you run to higher absolute numbers, that will hit statistical significance, but at 111 it didn't, and I think that's very sweet. And I want to point out that all of these cases were done by ST6 registrars. So this is in the second 6 months of the innovation. I'm not doing any of the surgeries in the high volume list. When I'm working on my surgery, I have a sort of algorithm in my head. My mode is 6 minutes, the median is 7, and the mean is 8. And I use an 8-minute assumption. But this is ST6s capable of performing at an incredibly high level, doing high volume surgery. And this is very impressive. These graphs are stretched to be equal. So it's percentages, not absolute time. So it makes them a little bit hard to eyeball. But in the high volume list, the dark blue on the far right with the red asterisks, the turnover time is half that or less than half that of the standard list. Now, in absolute terms, it would be short. The overall bar would be shorter. But if you stretch both of them to percentage terms, 100%, the turnover is half the time. Just as an aside, what is a bit of a shocking thing that we haven't improved, the amount of waste. So all these high volume lists put together, so that was 3.5 days, produced 140 kilograms of waste. Some of it is recyclable, but tragically little. Some of it is sharp, but that's not the majority. So this is something we really need to work on. Hospitals produce a vast proportion of national CO2 waste. Now, training is the stress in the system. And I said to the TPD, I would take either ST1s or ST6s, but nothing in between. The reasons for that are personal, that's fine. ST1s are happy to do bite-sized portions of an operation. ST6s can be legitimately expected to do all of it. So I start with a 1 hour time bank with the ST1, and I'll just make that more neat and legible. The idea is I program a list that I know I can finish by 4:15. I've got till 5:15. So those 60 minutes are given to the ST1, and how they use them is up to them. So this is real world data. So I gave the first case to the ST6, who is an unbelievably talented natural surgeon. She took 22 minutes to do the whole case. And I'm saying it would have taken me 8. So the deficit is 14 minutes. So my 60-minute gift to her has gone down to 46 minutes. The second case she did in 12 minutes. She's only used 4 minutes of her capital, if you like, her money in the bank. And as you can see, even after she's done 5 whole cases, she's still got almost half an hour to play with. So this surgeon, because of her natural fluidity and skill, will get quite a lot of surgery out of an all-day list at high volume. And around the country, I would say that most people object to the high volume, saying you cannot teach ST6s on high volume. I disagree. In the Golden Jubilee, an entire day's surgical list would stack up to about the first red line. This is the first 2 patients on an all-day list. Going through 24 sets of case notes is 60 minutes of work on the day before. So general hospital notes are not efficient for high volume cataract surgery, but c'est la vie. It is what it is. Other things that can improve flow, this is the 10 barcodes that we know and love on a BTS sample. It is said that engineers use ideas to kill problems. And what we want to do is get rid of some of the time-consuming WHO checks. Zebra technology, if you go for Scan and Shop in Asda, it's a Zebra scanner you'll be using, tried and tested. What I wanted to do was to put a QR code on the wrist, which has the code of the implant that will be used in that patient. Every implant, the boxes behind the nurse there, has a GS1 barcode on it, which will tell the make, the model, and the number of that thing. And the idea would be you scan the QR code, you scan the box, whilst the surgeon gets going. If it beeps happily, then you've got the right implant. If it rings a siren, you've made a mistake. We can go into this in Q&A if you're interested, but the point is, it would be an obvious way to do it. I put in a bid for about £3,500, which is peanuts, and the Innovation Centre knocked it back, saying it's not sufficiently innovative. And my response to that is, they are absolutely correct. This is not sufficiently innovative. Amazon have been doing this for 15 years. This kind of technology is old hat. The question is, why are we not doing it in NHS? But there's nothing particularly innovative about it, but it would shave time off. And the problem is time, because this is modern cataract surgery. We are where the airline industry was in 1945. In 2022, this is the kind of thing we're doing for booking. It should be possible to go on a website in the eye department and to say that actually there's been a no-show for the afternoon slot for cataract, and you're on the waiting list, and your daughter can get you to the hospital in 40 minutes, and you sign in and you take that slot, same as an empty seat in a train, and yet we have no idea how to do this kind of thing. The problem in healthcare is the efficiency thoroughness trade-off. If things are going well for me, Scottish Government are very happy that I'm highly efficient and we're doing high volume. If I make a mistake, what will take me to court is my lack of thoroughness. And the question is, these two are always in tension. How can you have your cake and eat it? How can you have both thoroughness and efficiency? And we have moved to a generic consent. We're just on the brink of piloting and trialing this. If you point your iPhone at the screen, capture that QR code, it'll take you to a 4-minute, 30-second consent video on cataract surgery in Tayside. So this was filmed by one of our registrars. It's much better than a normal consultant boring you with his discussion of risks and benefits. You can watch it with your daughter. You can watch it 3 times with your daughter. You can ask your son to have a look at it. And then you can decide if you consent to the surgery. And this is the kind of thing that we need to be moving to. Another medical student has prepared this, looking at the kind of the shift through the decades from the 2000s to where we need to get to now. Optoms are a huge workforce that are largely outside the Great Wall of China in terms of where we perceive them to be for ophthalmology. And given the manpower catastrophe that we described at the start, we need to use optoms as part of the journey. And they're delighted to do that. And they're highly skilled people able to do so. Right, we're at the end now. I want to talk about the magic sauce, because if I want to motivate the nursing team, and I want you to take away one thing, which is that the entire story here is a nursing success story. So every single thing that's been achieved is thanks to nurses that have been part of this journey to high volume. But the question is, why do they do it? My motivation is that I see a patient 4 weeks later, perhaps, who's got good sight, and they smile, and I can see the closure on that. The nurse will never see the post-op patient. Their closure is a day well done. In other words, the day itself must feel like a good day for it to be worth doing the job. There are 3 motivators I can think of. Number 1, I pay them more. I have no control over that. The NHS cannot do that. Number 2, if we work fast and get the work done by 3 o'clock, you can go home early. Ditto, I can't do that. So whatever the magic sauce is, it's in the 3rd box. Now, part of it is flow. So it's been said that you can have flow without happiness, but you can't have happiness without flow. So somebody in a factory making widgets might be bored to tears, but they're certainly in flow. But you've got to have flow, and everyone knows what flow is. I think you've got skill on the bottom axis and challenge vertically. So if you're high skill and low demand, that could just be you on holiday, relaxing in the dark green. If you've got low skill and high demand, that's the amber, the orange top left in anxiety. But clearly, to be in flow, the kind of sportsman place to be is high skill, high demand. And if you keep people in that position all day, the day is, as the motto was, more busy but less tiring. So we've got to create flow. So that's a given. Number 2, connection, which is to say teamwork, a sense of belonging, a sense of valuing your colleagues, getting on well with the nurses, respecting them. So this is a cohesive, good team is crucial to making everything work. And the 3rd thing I would say is possibly intrinsic reward, some sense that, see, money as a motivator is an extrinsic reward. If I do more, I get paid more. The world record, I believe, for a pit stop is the Red Bull team that changed 4 wheels and filled the tank in 1.8 seconds in Formula 1. If, as the car is about to pull in, 30 seconds before the car pulls in, you stop everybody and say, look, I'm going to up your salary by £10,000. Right, get back and do your pit stop. In the split-second pit stop, I don't think that 10,000 would make a difference. What makes a difference is they love what they do. And when the car pulls out and the board goes up and it says 1.8 new world record, they thump the air and hug each other. And at that particular moment, the salary is not the thing. It's the part of something exciting. You're part of a magic thing. Now, obviously, you want to be in the intersection of the 3 circles somewhere in there. But what's interesting is that is not actually, this is plagiarized. And intrinsic reward was not what was in the original lecture, which is on TED Talks by Catherine Price. What she put in the top one was playfulness. Now, the medical student that I was doing the Six Sigma analysis of things said to me, well, we know that if you games healthcare, so for example, an app that checks how regularly you've got your blood sugar within a target gets better engagement than just ticking in a diary. And so trying to create a sense of the day being part of a kind of exciting narrative. Playfulness seems a bridge too far in terms of the magic sauce, perhaps. But it is interesting that when a team is working well, the atmosphere in theatre is often cheerful. There's banter and people are having fun. I've always noticed that, but always thought that it was a slightly embarrassing lack of gravitas. But in fact, it's probably the start of a team working well together. So these are my tentative efforts to try and reverse engineer what is going on in a useful team making things happen. So I'm finished, and I'll leave you with Dundee's best export, Winston Churchill himself, with this quote. So we are trying to work with Scottish Government to see what other areas in Scotland may be interested in doing some of these things. But at the moment, Tayside is numerically speaking the biggest hitter in terms of cataract surgery, thanks to the nursing team here. So thank you for your patience, everyone, and welcome any questions.
Thanks very much, John. Masterful as ever. I think this is really very interesting stuff. I'm just going to bring up my chat window if there's any questions. Nothing in there as yet. I obviously have dozens of questions. First thing is bilateral operations. I remember that was not in favour 4 years ago. Why the confidence now to move to? Well, perhaps you could explain why we didn't do bilateral operations and then why the confidence to do them now. Yeah.
So one thing had to shift. So it's the perfect storm. Several planets had to align. Number one, the anesthetics were quite invasive, and what they did was they anesthetized the optic nerve. So the patient would have anopsia. And if you did that twice, I've only done it once in my career for a gentleman with too high a BMI even to contemplate a safe general anesthetic. His terror at being made bilaterally blind whilst fully conscious for the 4 hours until it wore off told me I'm never going to do this again. Now the anesthetic we use is topical only. We just can do bilateral cataracts with drops alone. The mucous membrane of the eye and the corneal nerves absorb the anesthetic. So that's stage one. Stage two is that people just started asking the unthinkable. So the Scandinavian countries, as usual, did it first. In the whole world literature, there have been 9 reports of bilateral infection. The first was in 1977 in Mexico, where they used no antibiotics at all. So let's exclude that. That leaves 8. In the remaining 8, in every single one, the principles I described of segregation of instruments were not obeyed. So arguably, it's never happened, bilateral infection. The best estimate we can make is that the risk is 1 in 28.5 million. The risk of somebody over 75 dying in an RTA when they drive to hospital on 2 separate occasions on a 10-mile journey is 3 times more probable than 1 in 28.5 million. So you're actually saving them from killing themselves when they drive on the second occasion. So it's just a question of the crossover of risk graphs. It makes it safer. And that's it. Having said that, do ophthalmologists adopt it? Not so much.
Yes, well, in my experience of ophthalmologists is that safety is a real priority, and quite rightly so, vision being such an important part of all of our lives. I have more questions, but others have questions as well. So I'm going to go, the first person was John Dowell, and then I think Tom McDonald before Graham Lease. John, do you want to speak your own question?
Yeah, I'll read the one about the risks. So,
John Dowell, do you want to actually say your question, or do you whilst you're there?
If John's read it, not much point in repeating.
Thanks. Yeah, too many Johns. We work on an infection rate, which is a sort of sentinel event of, we always tell the patient 1 in 1,000. In Sunderland, in 6,500 in a year, they had 1 case of infection. So the problem with an event rate like that is if you doubled it, it would take you something like 3 decades to notice. So you've got to be really circumspect about bragging, because you could be doing dangerous things, but there's nothing in the actual surgical moment that has changed the surgical process to make that more probable. And I've just described the bilateral infection thing, which has got to be worked out in the cognitive realm, not the emoting one, because it's really a cognitive discussion. So infection, we're not seeing any difference. In terms of surgical complications, we're not seeing any difference. The one that's interesting is that in order to run this conveyor belt or motor faster, we're beginning to move to optician listing of patients. Now, that's not novel. Ayrshire and Arran and Inverness, because of geographical things, the Highlands and Islands, for example, have been doing that for 20 years. So even if we did it, you'd say, well, that's not really a post-pandemic haste. That's just catching up with reality. But the predictive validity, the problem with ophthalmologists moving to opticians listing is that whenever you say to ophthalmologists, they will sit in a meeting and virtue signal and tell you a tigers in the grass story. That they'll say, but I can tell you of an optom who missed the following rare finding. And my response to that would be, yes. And what happened when you found it? Did it make any difference to the outcome for the patient? And there are 7 red flags. And I believe that all 7 of them can be spotted on the table and dealt with at the time of surgery. So I'm not that sure that failing to spot them is a catastrophe. So I'm meandering in my answer, but we've not seen any rise in complications. We wouldn't particularly expect them, but even if we did, they would come from other aspects of the chain rather than the high volume surgery itself. I'll give you one last statement, which is very interesting. England and Wales collect all their data in a way that Scotland doesn't for cataracts, in a thing called the NOD, National Ophthalmic Database. The head of NOD, a guy called John Buchan, who's a Scot, was on a meeting that we had back in February. And he said something very interesting. He said, when it comes to be my turn for cataract surgery, I really don't care who does it. I've only one requirement, that is he must be a surgeon who's doing 24 a day. And the statistics show that a 24-a-day surgeon has half the complication rate of a 12-a-day surgeon, who in turn has half the complication rate of a 6-a-day surgeon, which is exactly what you'd expect with craft skills. The more you do, the better you get. So the naysayers are probably best rebuked gently by saying, come and join us and do more numbers, and you will both enjoy it more and be safer.
Tom McDonald, you have your hand up.
Yes. John, nice to see you again. It's not very often I'm quoted in an ophthalmology lecture. And just to say that the HOPE study, I mean, there's been lots of studies since then, but translating HOPE into practice has not been easy. And the current average dose of ramipril is 2.5 milligrams, which is pretty close to placebo. And we haven't implemented the HOPE study properly. And so life goes on. We prescribe ramipril in low dose to treat ourselves and not necessarily an evidence-based. There's no answer to that, I suppose, but I suppose there's similar things in ophthalmology.
Yeah, if I could comment on that, Tom, point well made and well taken. There's a story of an ancient yokel farmer leaning on a fence, and the new buck comes down saying, get rid of your horses, I'll sell you a tractor. And he gives a spiel about increasing yield. And the farmer says, son, I don't farm as well as I know how to already. And I think the problem with the ISBCS, with the ramipril, is that we assume that if people are told the evidence and the truth, that will change behavior amongst our colleagues, and it doesn't. So what we need to do is change fashion and change culture. And those two things are probably more likely to lead practice change than endless publications. And I think what's interesting for me about this venture, which is new territory for me, is that in dealing with politicians and managers, the very restrained vocabulary that you use as an evidence-based practitioner, which is you must never claim beyond what the paper says. But when you're dealing with culture change, there's a little bit of flamboyance. There's a sort of talking up the drama of what you're doing and the gains to be had for the population. And these are kind of conversations that clinicians are fairly restrained about. Normally, we don't go beyond what can be demonstrated, but actually we're trying to change. I repeat myself, but fashion, I suppose, is a good word for it. And I think it's trying to leverage much more primitive motivators of our colleagues, like the joy of doing a good day's work. So the magic sauce thing applies just as much to surgeons as it does to nurses. And if you say, look, when you have your craft skills increased and your surgical complication rates go down, what's not to like? Why wouldn't you want that? And that actually begins to change people's practice, really. So yeah, it's a fun business to try and work out motivators.
Graham Lease is that farmer stood against in a field. At least that's what his background looks like. So Graham, you have a question.
Yeah, no farming here, I'm afraid. So no, John, I was just wanting to ask you about non-surgical options. I know we've discussed ultrasound and that kind of thing being tried, and I know the people that are doing that have found it very difficult to get funding for what sounds like quite an exciting area, and there may be incentives to why they're not getting the research funding that they need, but that's perhaps too cynical. But I don't know, you have any thoughts on any of that, or are there any other non-surgical options? Because to me, that's really what's needed to go forward, isn't it, in bulk?
Yeah, interesting point. So unless I've misunderstood, to unpack that for those who may not have heard, that there's a Chinese company that's looking at using a particular wavelength of light shone in through your pupil, which might retard the disintegration of the crystalline lens you were born with and slow cataract development in the first place. And it's famously noted that symptomatic cataracts will occur in the 30s and 40s of people in hot countries. Incidentally, it may not be UV light. It's far more likely to be episodic dehydration if you're working out in the fields than it is. It's a hard life and poverty that causes it rather than UV and sunbathing in your yacht in St. Moritz. So the question is, can you slow it down medically? I think the problem is you might argue that a surgeon is most likely to be poo-pooing this, and therefore that's a bias, cognitive bias in me. But in fact, what happens is not just that the lens changes, but there's cellular degradation and disintegration, and to realign cells that have already begun, phospholipid membrane decay, it seems unlikely. And the problem is you might have to start in your 20s. You might have repeated interventions at a slit lamp of light. The irony is that the operation, which globally can be done for $10, the reason it's done at ridiculously expensive prices in the West is industry rather than surgeons. Surgeons are very happy to do this quite cheaply, I think. My surgical costs in terms of salary are £7.50 a cataract. So that's less in the NHS. That's much less than a haircut. Not that I would know anything about that. So surgeons' fees are not really the problem here. And you could get usables, disposables down quite a lot. There are ways in which surgery, which is 8 minutes and never needs to be repeated, it is the paradigm par excellence of fire and forget missile. And the cataract surgery gains the evidence, the Center for Value-Based Medicine in the US, 800 interventions across the whole of medicine, 8% value gain in life on most of them. Ophthalmology, 20% for the top interventions, and cataract's the best of the lot. So, it's a phenomenally effective healthcare intervention. Cost per quality is, and the famous top of that chart, of course, is anti-smoking advice by GPs, but it's nearly up there. So to do non-medical improvement in cataract, it's got a very, very tough job to prove it's better than surgery. And I know that surgery seems drastic and irreversible, but it is phenomenal. The complication rates are down at sort of 1 or 2%. My venture, which NHS Tayside is fully in support of, is to try and get nurses doing cataract surgery. I believe that's eminently doable. Clearly, the manpower problem in ophthalmology is powerful and significant, and I think that's possible. So we're hoping to have our first nursing training academy for Scotland here. There is a lot of support for that. Yeah, watch this space.
Thanks.
So I take it, John, that L. McNeish's question, which is, they have recently read about castor oil drops into the eye can help dissolve cataracts. Do you know anything about this? I suspect is that castor oil close to snake oil?
Yeah, I'm afraid it is. So the problem with the lens, which just, a little bit of, a patient might ask you about this, and how would you know? If it's not castor oil, if it's something that's got a much cleverer name, an IMAB, then somebody might say, well, surely that. The problem is the lens is 77% protein. The next contender in the body is, in terms of protein level, is skeletal muscle at 26%. It's a syncytium. There's no interstitial fluid. It's nothing but a low metabolic complex of cells. The first one you ever made in utero is still in the middle, and the one you added yesterday is on the outside. And it's just getting progressively more and more compact. And anything drug-wise that you want to get into the middle cannot penetrate because the cells are hexagonal in shape. They don't have much transmembrane transport of anything. And once the proteins begin to denigrate in the center, there's no nucleus, there's no RNA, there's nothing, denucleate cells, there's nothing to metabolize a sort of antioxidative stress thing that would reverse those changes in those cells. So even if an oil could penetrate into the anterior chamber, which of course it can't, it cannot do anything to re-architect the beauty of the crystalline lens. And architecture is everything. If something is glass clear, but made up of opaque protein, that's clearly an incredibly impressive molecular structure, and you can't just remanufacture that through metabolic names and metabolic process in cells that have no metabolism at all, more or less.
As suspected, but more eloquently put than my dismission of it being snake oil. One last question is that, for me at least, is that some people need to have this done under general anaesthetic. And so where do they fit into this? Because if the vast majority are getting it under local and underdone through the high volume process, you don't have a GA list anymore. So what happens to those?
Yeah, thank you. So the interesting thing for GAs is who needs a GA. So the list would be the incredibly frightened, the incredibly young, and special needs. Anything else? Now, the incredibly frightened, increasingly, I'm sure you'll, the acronym NLP, neuro-linguistic programming, we all do it instinctively. So I don't say to the patient, would you like a local or a general? The statement is, we do these under a local. Now, clearly this is basic NLP, but that plus all the other finessed versions of it that we've learned over the years. So that the proportion who really want a GA and cannot be talked out of it has collapsed to possibly 1 in 500. Post-pandemic, people also understand that the waiting list for general anesthetic is 1 year, and the health benefits and risks are different than they used to be. So special needs, yes, and there is some of that. Interestingly, one group that might need a general anesthetic that I haven't mentioned is people who had previous retinal detachment surgery, because especially if there's a strap around the eye, which is a buccal surgery, that retards the distribution of local anesthetic deeper into the tissue. So that's fine. Look, a general anesthetic for that, that's fine. But those numbers are not prohibitive to the process, so we can still accommodate those. But I guess all of which to say, far fewer than you would think. And the move topical means that you don't really have to fear an injection. It's really pretty benign, and patients can be got through it with TLC and a lot of positive spin.
And I imagine it must be. I mean, you've mentioned about being frightened. I've had a couple of my surgeries done under local anaesthetic, and it's perturbing, but you kind of settle in and take a few deep breaths. It's quite remarkable, I think, that it's not quite so, it isn't so terrifying, and perhaps that is, well, undoubtedly is down to, as you say, a bit of NLP, but just a professional attitude for the whole team and the reassurance of the whole process. Right, does anybody else have any questions for the last couple of minutes? I think they're probably there. Well, I'm so pleased I managed to cajole you into this, John. Fantastic talk. I think just a demonstration that with some given time and a small amount of resource, but mainly the time to think about it and the time to work out what are those problems and what can and will work. You've made a phenomenal difference to the service, to the staff who work with you, but more importantly to the lives of those double people that you're now treating. I think it's absolutely amazing, absolutely amazing. And I suspect you're shooting off to go back to theatre to do some more.
Yep.
So thank you very much.
Thank
everyone.
You.
Next
Thanks,
week, everyone. We move to obstetrics with neonatal testing. I think I can't remember who's speaking, but I think Tony Nicol, another cyclist, is going to be part of that process. So I'll send an email out next week to tell you about that. This ground on, like all others, will go onto YouTube once I have uploaded and edited it. And there will be if you subscribe to the YouTube channel, press the wee bell, then you'll get notifications of when the talks go live. Thank you very much for your attention. Thanks again, John, and enjoy the snow.